Welcome to our presentation on Edoxaban, a direct oral anticoagulant branded as Supexod. Introduced for the first time in India by Zuventus Healthcare, Edoxaban offers an advanced option for managing thromboembolism and atrial fibrillation. In this session, we will explore its role in these conditions, review supporting clinical evidence, and understand why it represents a significant advancement over traditional anticoagulation therapies. Venous thromboembolism and atrial fibrillation represent substantial global health burdens, leading to stroke, hospitalization, and even death. Managing these conditions effectively is crucial, especially in aging populations. Anticoagulants are classified by route of administration, either parenteral or oral, and by their target, such as thrombin, factor Xa, or factor IXa. Established and new agents include drugs like heparin, fondaparinux, dabigatran, and direct factor Xa inhibitors such as rivaroxaban, apixaban, edoxaban, and batrixaban, alongside vitamin K antagonists like warfarin. Traditional anticoagulants like warfarin have a narrow therapeutic window, a variable dose response influenced by genetic and dietary factors, numerous drug-drug interactions, a slow onset and offset of action, and a long half-life. They also require frequent monitoring and dose adjustments, all of which can compromise patient convenience and safety. Non-vitamin K oral anticoagulants, or NOACs, were developed to overcome these limitations. Edoxaban is one such NOAC, with a clean, well-defined mechanism, direct inhibition of factor Xa, allowing predictable anticoagulant effects and fewer interactions. Non-vitamin K oral anticoagulants like apixaban, rivaroxaban, and dabigatran have transformed anticoagulation therapy by reducing the need for monitoring and dietary restrictions. However, clinical limitations remain. Many require twice-daily dosing, which can affect adherence. Rivaroxaban and dabigatran show similar major bleeding risks as warfarin, with rivaroxaban linked to higher rates of gastrointestinal bleeding. These concerns highlight the ongoing need for a more optimal oral anticoagulant. Edoxaban is a novel, potent, and highly selective direct inhibitor of activated coagulation factor Xa, factor Xa, a pivotal enzyme in the coagulation cascade. What distinguished edoxaban is its exceptional selectivity, demonstrating over 10,000-fold greater affinity for factor Xa compared to thrombin, resulting in precise anticoagulant activity with a favorable bleeding risk profile. It belongs to the class of direct oral anticoagulant drugs and provides consistent once-daily anticoagulation. Edoxaban acts as a selective, competitive, and direct inhibitor of factor Xa, working independently of antithrombin 3. It effectively inhibits both free factor Xa and factor Xa bound within the prothrombinase complex, thereby halting thrombin generation and clot formation. Additionally, edoxaban curbs platelet aggregation induced by thrombin, offering an added layer of thromboembolic protection. Edoxaban has been globally approved and is currently marketed in several regions: Japan, European Union, United States, India, approved by the Central Drug Standard Control Organization (CDSCO). In India, edoxaban is being introduced and marketed by Zuventus Healthcare Ltd. Edoxaban is indicated for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation, NOAC, and for the treatment and prevention of venous thromboembolism, VTE, including deep vein thrombosis, DVT, and pulmonary embolism, PE. Dosage and administration for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. The recommended dose is 60 mg once daily, following at least 5 days of parenteral anticoagulation when switching from heparin. And for the treatment and secondary prevention of pulmonary embolism and deep vein thrombosis, the dosage is also 60 mg once daily, again after an initial parenteral lead-in. The treatment should continue for a minimum of 3 months, and can be extended based on the patient's clinical needs and risk factors. Reduce the dose to 30 mg once daily in patients with moderate to severe renal impairment, creatinine clearance between 15 and 50 ml per minute. Body weight of 60 kg or less. Concomitant use of P-glycoprotein inhibitor medications such as cyclosporin, dronedarone, erythromycin, or ketoconazole. Assessment of renal and hepatic function is essential before initiation and periodically during therapy. Before initiating edoxaban, assess renal function using creatinine clearance. Re-evaluate during treatment if renal function may have changed. Liver function tests are also mandatory prior to starting therapy. Edoxaban is not recommended for use in children and in individuals up to 18 years of age. This recommendation is due to the current lack of robust efficacy and safety data in the pediatric population. Edoxaban should not be used in patients with uncontrolled severe hypertension, active bleeding, severe liver disease with coagulopathy, during pregnancy or breastfeeding, or those on other anticoagulants. If a dose is missed, it should be taken immediately on the same day. Do not take 2 doses to compensate. Resume the regular once-daily dosing schedule the next day. Edoxaban simplifies treatment by no INR monitoring, can be taken with or without food, and no routine dose reduction is needed for elderly patients. Prior liver function testing remains essential. The most common adverse reaction associated with edoxaban is bleeding, including risk of bleeding, spinal and epidural hematoma. Other reported adverse effects include abnormal liver function tests, rash or hypersensitivity reactions. Clinical experience with edoxaban overdose is limited. Reversal agents, andexanet alpha can be used. To switch from vitamin K antagonists, discontinue warfarin and initiate edoxaban when the international normalized ratio is at or below 2.5. For oral anticoagulants other than VKA, discontinue the drug and start edoxaban at the time of the next dose of the oral anticoagulant. Parenteral anticoagulants should not be administered simultaneously. Discontinue subcutaneous anticoagulant and start edoxaban at the time of the next scheduled subcutaneous anticoagulant dose. For surgery or invasive procedures, discontinue edoxaban at least 24 hours before the procedure in patients with normal renal function. Extend the discontinuation interval in patients with renal impairment. As with all anticoagulants, the risk of bleeding increases with concurrent use of other medications affecting hemostasis, such as nonsteroidal anti-inflammatory drugs, antiplatelet agents, and other anticoagulants. Edoxaban stands out among oral anticoagulants for its favorable pharmacological profile and practical advantages. Like rivaroxaban and apixaban, it is a direct factor Xa inhibitor, while dabigatran targets thrombin, factor 2A, and warfarin acts as a vitamin K antagonist. One of edoxaban's key strengths is its rapid onset of action, with peak activity reached in approximately 1.5 hours, faster than rivaroxaban, apixaban, and especially warfarin, which requires 24 to 36 hours. Its half-life ranges from 10 to 14 hours, supporting consistent anticoagulation with once-daily dosing. This once-daily regimen is particularly advantageous in enhancing adherence and simplifying patient management. Edoxaban has relatively few drug-drug interactions, as it does not inhibit cytochrome P453A4 and is only a substrate of P-glycoprotein. In contrast, anticoagulants like rivaroxaban and apixaban interact with both cytochrome P453A4 and P-glycoprotein. Edoxaban's 50% renal elimination and minimal hepatic metabolism, approximately 4%, make it a safer option for patients with renal or hepatic impairment. Additionally, edoxaban is not a prodrug, has no food-related restrictions, and can be taken with or without meals, unlike warfarin and rivaroxaban. Edoxaban is recognized globally for its clinical utility and safety. It is included in the WHO model list of essential medicines, underscoring its importance as a core treatment in health systems worldwide. The American Society of Hematology, ASH. 2020 guidelines recommend edoxaban over vitamin K antagonist for the treatment of DVT and PE. The American Society of Clinical Oncology, ASCO, 2023 endorses edoxaban as a preferred option for cancer-associated venous thromboembolism. Additionally, the European Society of Cardiology, ESC, 2024 recommends edoxaban for stroke prevention in patients with non-valvular atrial fibrillation. Zuventus Healthcare Ltd conducted a bioequivalence (B.E. Study in 80 healthy adult human subjects to compare its Supexo-D 60 mg film-coated tablets with the reference product, Lixiana 60 mg tablets manufactured by Daiichi Sankyo Europe GmbH, Germany. The 90% confidence intervals for Cmax and AUC fell within the accepted bioequivalence range, confirming that Supexo-D is bioequivalent to Lixiana, with comparable rate and extent of absorption. Edoxaban has been extensively studied in various clinical trials to evaluate its efficacy and safety in preventing stroke in patients with atrial fibrillation and treating venous thromboembolism. The ENAGAE-AF 48 trial was a landmark study involving over 21,000 patients with atrial fibrillation. It compared two doses of edoxaban, 60 mg and 30 mg once daily, with warfarin over a median follow-up of 2.8 years. Both doses of edoxaban were found to be non-inferior to warfarin in preventing stroke or systemic embolism. Notably, the high-dose edoxaban group experienced a 20% reduction in major bleeding, while the low-dose group showed a 53% reduction. Additionally, edoxaban was associated with fewer cases of intracranial hemorrhage and cardiovascular death, confirming it as a safer alternative to warfarin. The ENAGAE-AF trial evaluated edoxaban in patients undergoing electrical cardioversion, a procedure used to restore normal heart rhythm. Over 2,000 patients were enrolled and randomized to receive either edoxaban or the traditional enoxaparin warfarin regimen. Edoxaban was non-inferior in preventing thromboembolic events, including stroke and myocardial infarction. The study demonstrated that edoxaban is a simpler and equally effective alternative to conventional anticoagulation during cardioversion. The ELDERCARE-AF trial focused on elderly patients aged 80 years and older who were considered unsuitable for standard anticoagulation therapy. Participants received either low-dose edoxaban at 15 mg daily or placebo. Edoxaban significantly reduced the risk of stroke or systemic embolism, with annual rates dropping from 6.7% in the placebo group to 2.3%. The trial confirmed that low-dose edoxaban provides meaningful protection for frail elderly patients with an acceptable safety profile. The ESCAPE trial studied 176 atrial fibrillation patients aged 80 and above, all treated with either edoxaban 60 mg or 30 mg. The composite outcome, including stroke, major and non-major bleeding, and all-cause mortality, showed similar event rates across all groups, with no significant differences observed. These findings demonstrate that edoxaban, at appropriate doses, is a safe and feasible anticoagulation option for elderly AF patients, regardless of frailty status. The Hokusai VTE trial evaluated edoxaban in over 8,000 patients with acute symptomatic venous thromboembolism. Following initial heparin therapy, patients were randomized to receive either edoxaban or warfarin for a duration of 3 to 12 months. Edoxaban was shown to be non-inferior to warfarin in preventing recurrent VTE, with event rates of 3.2% versus 3.5%, and a slightly lower risk of major bleeding, 1.4% compared to 1.6%. The study included 1,000 patients from India across 36 centers, reinforcing edoxaban's global relevance and confirming its role as an effective and safer alternative for VTE treatment. VTE prevention trials. These trials evaluated edoxaban for the prevention of VTE following orthopedic surgeries, including total knee and hip replacements. In the STAR-Z3 study, edoxaban significantly reduced the incidence of VTE in knee surgery patients compared to enoxaparin, while maintaining a similar safety profile. The STARS-J3 trial showed that edoxaban effectively prevented VTE in hip replacement patients. The STARS-JV study extended these findings to other orthopedic procedures, consistently demonstrating edoxaban's efficacy and safety. Together, these studies support edoxaban as a superior option for thromboprophylaxis in high-risk surgical settings. Real-world cohort study. A large observational study examined edoxaban's performance outside of controlled clinical trials. It evaluated its safety and efficacy across a diverse patient population in real-world clinical practice. The findings were consistent with those of earlier clinical trials, reinforcing edoxaban's practical value and reliability in everyday use. Edoxaban offers significant clinical advantages as a selective factor Xa inhibitor, providing effective thromboprophylaxis with a lower bleeding risk. Its rapid onset of action, achieving peak plasma levels within 1 to 2 hours, and 24-hour duration support convenient once-daily dosing. Edoxaban also has a strong safety profile, demonstrating reduced rates of major bleeding, particularly intracranial hemorrhage, and no associated hepatotoxicity. Additionally, the absence of food-drug interactions and minimal drug interactions enhance its flexibility in diverse patient populations. Robust real-world evidence supports Edoxaban's superiority over warfarin and select DOACs in reducing both stroke and bleeding risks. Its elimination of INR monitoring is highly valued by patients, promoting greater freedom and adherence. Endorsed by leading medical organizations, Edoxaban stands out as a trusted, guideline-recommended anticoagulant. Edoxaban offers a safe and effective alternative to traditional anticoagulants like warfarin. With once-daily dosing, predictable effects, and a lower risk of major bleeding, it is a valuable option for long-term anticoagulation in NOAC and VTE patients. We appreciate your time in reviewing this information and hope it provides a clearer understanding of Edoxaban's potential benefits in clinical practice.